Morning, everyone. Thank you, the organizers. Thank you, Warren, for inviting me. As Warren mentioned, I'm a dermatologist and dermatopathologist. In dermatopathology, what we do is we receive the skin tissue specimens that your providers will biopsy and send to us for diagnosis. So, the questions we ask ourselves every day in practice is this skin cancer? And you would think that it would be kind of an easy distinction, but it's often not. And so today I'll talk to you about kind of a little bit about our work and trying to understand what causes skin cancer. And that will help us to prevent skin cancer. Okay, well, so this is a histologic image of the skin. Just to orient everyone, the purple part at the top is the epidermis, the outermost portion. And then here we have the dermis. Here's a hair follicle. There's some solar elastosis here. We'll highlight that. Sebaceous glands. And when we're talking about, when we zoom in closer, we can see the keratinocytes are here at the surface. Then we have the melanocytes. They're almost very difficult to see, but they're these individual cells that are in the lower portion of the epidermis, and they make the pigment that protects our skin. And typically, they're just these single cells that are scattered in the basal layer of the epidermis. Then we might also have lymphocytes. And here we can see this bluish material in the dermis. That's solar elastosis, and that's a mark of UV damage that's been occurring in the skin. And we use that to kind of score how much solar damage has been occurring. Since this is a talk about skin cancer, I'll talk quickly about carcinomas of the skin. They're common. So there are common types and rare types. So squamous cell carcinomas and basal cell carcinomas arise from the epidermis that I showed you before. And then we have rare subtypes of skin cancers like sebaceous carcinoma, Merkel cell carcinoma, and other carcinomas. So generally, how does cancer develop? And it's considered to be a genetic disease that you accumulate genetic mutations that cause genes to become overactive, that tell the cells to proliferate, or break genes that are the natural brakes on the cell growth. It's called tumor suppressors. And it doesn't take usually just one mutation to progress to cancer. And we can actually see a progression in some cases where you first have, a normal cell, it acquires a mutation, you get a benign growth or a benign neoplasm that will grow into a pigmented lesion or a bump that will remain stable. That may accumulate additional mutations, and then we may have changes that we consider precancer, still not cancer, but at a higher risk of becoming skin cancer. And then we'll end up with a cancer, either a carcinoma or a melanoma. So we can divide tumors into epidermal tumors and melanocytic tumors. Here's some examples of epidermal tumors. Here we have, can you see my arrow? Where's the pointer going? How about now? This is a solar lentigo, a seborrheic keratosis. This is an actinic keratosis, considered a precancer, where you have more atypical cells. And you can see this lesion is inflamed. There are lymphocytes here, so the immune system actively sees this neoplasm and is causing this inflammatory response. Here we have squamous cell carcinoma in situ. It's thicker, the cells are atypical, they're growing in a disorganized fashion throughout the entire epidermis. And then here in this lesion, we have a carcinoma where the atypical cells are now leaving the epidermis, going into the dermis and invading. And so that's carcinoma. So we can think about the progression stages of these different epidermal neoplasms, from lentigo to seborrheic keratosis to precancer like actinic keratosis, and then finally to squamous cell carcinoma through the accumulation of mutations. Now, interestingly, there was a study looking at quote unquote normal skin. And so in this study, they took skin tissue from eyelid surgeries, blepharoplasties, and they took small samples from the eyelid and they sequenced those. And what they found was that there were these little clones within the skin. So the skin looked normal, but they could see that these different small patches had the same mutation within them, indicating that one of the cells in that area got a mutation and then started growing within a small area. And here you can see in this picture here, this is what the clones look like. Each circle here represents a patch of cells that all contain the same mutation, in this case here, a FAT1 mutation. And then the other circles contain additional mutations. So you can see that even in normal skin, you have an outgrowth of cells that have these oncogenic mutations. And when you look at normal skin, there's a certain number of mutations there. But when you look at the different skin cancers, both squamous cell carcinoma, basal cell carcinoma, and melanoma, you see that many of the tumors have a very high mutation burdens. And it's been shown that these mutations carry a signature of UV radiation, so indicating that they're caused by UV exposure. Now on to melanoma. Looking at the genetics of melanoma and the clinical situations in which we see melanoma, we know now that melanoma is not one single disease, and we're working on stratifying them into different categories to help with diagnosis and giving patients an idea of their prognosis. There's the low cumulative sun damage melanoma, which is maybe one of the most common ones. This is the type that might arise from a pre-existing nevus. Then we have high cumulative sun damage melanomas. These occur on very skin with a lot of sun damage, and they may often occur first as a patch that spreads radially. We have acral melanomas that occur on the hands and feet and the nails. Mucosal melanoma can occur in the sinonasal cavity or genital urinary system. And then we have melanomas that may occur in the eye, uveal melanoma. We also have these congenital nevi, children that are born with large melanocytic tumors that are benign, but they have a higher risk of progressing to melanoma, so melanoma from congenital nevus, and then another subtype called Spitz melanoma. So when we think about melanoma, we have the nevus that occurs from a single mutation, and then melanoma occurring from multiple mutations. And then we have this in-between category, which we're working on figuring out, the melanocytoma, atypical nevus, dysplastic nevus, or melanoma in situ. So how does that pertain to you? By having these diagnostic categories and kind of sorting them out, we can figure out how best to treat the different lesions. So for the melanocytic nevus, we should leave it alone. It has a low risk of progressing to melanoma, so biopsy or surgery is not needed. For these tumors here, there's kind of some uncertainty about what is the best method for treating them. So typically these are treated with surgery, but the margins, how much extra normal tissue we take around them, it's not agreed upon by everyone. So we still need to kind of understand what is the risk of these lesions progressing. And then for melanoma, we have standard therapies. Here's again just a graph showing the number of mutations across all different cancer types. And melanoma, you can see here, on average, has one of the highest numbers of somatic mutations. Again, it's not, there's a wide distribution. So there are some melanoma subtypes that have very few point mutations, and we don't think that they are caused by UV radiation. So what are some strategies to prevent skin cancer? We want to avoid mutagens. So I think everyone probably knows that sun exposure is not good for you. You should avoid mutagens. And not only is that, seeking shade, using sun protective clothing or sunscreen, but we can think about kind of societal methods to avoid sun exposure. So in Australia, where they have huge amount of skin cancer, for after school sports, they try to do them not at 3 p.m. when school lets out and the sun is pretty bright, but they put the practices that are outdoors early in the morning or later in the day to kind of avoid peak sun exposure. So we want to think about how, we can manage sun exposure for children through community mechanisms. Then there's also screening to detect precancers and early skin cancers. These can be modified based on personal risk. So if you have a lot of atypical appearing nevi, each of those nevi has some risk of progressing to melanoma. If you have 200 nevi, you're at higher risk than a person that has 10 nevi. In addition, we know that there are germline alterations that can be associated with melanoma. So if you have one of these conditions, you may need closer screening. Treatment of precancers, so destruction of things like actinic keratoses, excision of atypical nevi. Some people are now thinking of melanoma in situ as a pre-cancer, a pre-melanoma, so excision of those or topical treatments with immunotherapies, and of course, early detection. So we know for melanoma, the tumor stage, millimeters matter. 1 millimeters to 4 millimeters. It's a very small physical distance, but the survival rates for these different thicknesses of tumor are quite drastically. So again, sun protection to avoid mutagens. And then this graph here is just to show that there was a study that looked at sun exposure and the number of nevi, and the more sun exposure you have as a child, the more nevi you will have as an adult. And these are risk factors for developing melanoma. And another, thinking to the future, how else can we prevent melanoma? This is a child, these are pictures of children with congenital nevi. These are all precursor cells for melanoma. We can think about how can we reduce the burden of melanocytes in these children to reduce their risk of progressing to melanoma. And here's an example of a nevus here in the background in which melanoma has developed. So kind of keeping an eye on nevi and maybe reducing the overall number of benign cells that are at risk for progressing. So just to talk about how to detect melanoma, early detection and high-risk precursors, we have the ABCDs of melanoma, so asymmetry, irregular border, different coloration, the diameter is greater than the end of a pencil eraser. And I think this one is really important for patients, and that's evolution, because it's the easiest for patients to kind of track how their own pigmented lesions are evolving. And you can imagine, if you have a number of nevi, it can be challenging to monitor all of them and look for things that are evolving. Identifying patients at increased risk of melanoma for increased screening, for genetic testing, if there are 3 or more melanomas in an individual, especially if one occurs before age 45, 3 or more cases of melanoma or pancreatic cancer on one side of the family can indicate genetic predisposition to melanoma. And we're starting to learn more and more about different genes that contribute to melanoma predisposition. This is a melanoma affected family, so you can see that there's melanoma occurring at high frequency in this family. So we showed the picture of the patient with the multiple irregularly pigmented papules. BAP1 germline mutations also confer cancer risk. This is a alteration that was described about 10 years ago, and they have a distinct presentation. So oftentimes you'll have these small brown papules, and then within those you'll have these orange raised lesions that will develop. And if you get a biopsy, it will be quite distinct on biopsy. So your dermatopathologist might recognize, oh, this is a tumor with loss of this particular tumor suppressor. And then if you have multiple of these, or you have a clinical presentation that matches, maybe someone will suggest to you that you be screened for a germline alteration, meaning a mutation that's present in every cell of your body that is predisposing you to developing these specific melanocytic tumors or melanoma. And with that, I'll just leave you with, again, this is how we think about skin cancers developing, mutations accumulating in cells, progressing from benign to precancer to cancer, and then just avoiding mutagens and recognizing lesions early to prevent progression. Thank you.